Hi guys, welcome to Podcast Med. The topic of discussion in this podcast is arterial diseases, and this is the part one of the arterial diseases where I'll be discussing the remaining parts of arterial diseases in the upcoming podcast. So, coming to the surgical anatomy that is regarding arteries, we'll go with first thoracic outlet. Thoracic outlet is bound normally posteriorly by spine, anteriorly by manubrium sterni, and laterally by first strip. The vessels coming out of this, which are carotid arteries, and it can be external carotid, internal carotid as well, common carotid as well. All of these are of significance in arterial diseases. And coming to the other parts of arteries which are important is arteries of upper limb and arteries of lower limb. Coming to arteries of upper limb, we have the main supply, arterial supply of the upper limb starts with subclavian artery, where it gives off axillary artery, and axillary artery is divided into three parts by scalenus muscle. And first part contains one artery, second part contains two arteries, and third part contains three arteries. And then after these three parts, axillary artery gives off brachial artery, and brachial artery will be divided into radial artery and ulnar artery. Coming to the third part of axillary artery, which is important here, it gives off anterior circumflex humeral artery, and posterior circumflex humeral artery. And then it also gives a subscapular artery, which further divides into circumflex scapular and thoracodorsal arteries. So this radial and ulnar arteries will go into the hand, may form coming to the cubital anastomosis. This is where the different arteries will make anastomosis near the cubital fossa in the elbow joint. So then after the anastomosis, the brachial artery gives radial artery, ulnar artery, and posterior and anterior interosseous arteries, which supplies the interosseous membrane between the ulna and radius. Then after this, it will form the arterial arches in the hand, which applies different parts of the hand and forearm. Coming to the arteries of the lower limb, the common iliac artery from the abdominal aorta will give external iliac and internal iliac arteries. External iliac artery gives off femoral artery, where it gives rise to profunda femoris artery, and internal iliac artery will give superior gluteal artery and inferior gluteal artery, which help in the anastomosis near the thigh region. And other anastomosis in the region are by the branches, that is perforator artery branches coming from the profundofemoris artery, which form cruciate anastomosis in the thigh basically. But cruciate anastomosis particularly, it is by inferior gluteal artery, first perforator artery from the profunda femoris, and second perforator artery from the profunda femoris, and other arteries. Coming to the after anastomosis part, after anastomosis, the femoral artery passes into the popliteal fossa as popliteal artery, and then popliteal artery divides into posterior tibial and anterior tibial. Anterior tibial, after the due course, continues as dorsalis pedis artery. Coming to the posterior tibial artery will give off the peroneal artery branch, and posterior tibial artery continues like that itself. And nutrient artery for the tibia is given by posterior tibial artery, and nutrient artery for the fibula is given by peroneal artery. After that, there is a communicating branch between the two arteries, and then there is perforating branch coming from peroneal artery. Then after that, posterior tibial artery gives medial malleolar network, and peroneal artery gives lateral malleolar network, as well as posterior tibial artery gives medial calcaneal branches, and peroneal artery gives lateral calcaneal branches, and the blood supply of the lower limb ends like that. So after this, we'll go with arterial diseases. Arterial diseases can be stenosis, dilatations, arteritis, inflammation of arteries, basically some vessel abnormalities as well. To study all of that, first we have to discuss about intermittent claudication. What is intermittent claudication? It is basically a crampy pain in the muscle which is brought by the exercise, and it is relieved by rest and is reproducible. It can again reoccur, and it is common in lower limbs basically. And then it is due to arterial stenosis or occlusion, and the pain is because of the lactic acid and substance P accumulation in the muscles. Okay, pain in the buttock is due to block in the common iliac or aortoiliac segments, 30%. Often it is associated often with impotence. So this is called by a name called Lerich syndrome. Okay, there are other sites of pain as well. This is one side, pain in the buttock, and other sites of pain can be calf muscles, pain in the foot, the pain in the thigh, etc. And coming to the classification, we have 3 grades of classification. The classification is the Boyd's classification of claudication. First, grade 1, where the patient complains of pain after walking and distance in which pain after walking, and the distance in which the pain develops is claudication distance. Then coming to the grade 2, pain still persists on continuous walk but can walk with effort. The patient can walk with effort. Grade 3 is where patient has to take rest to relieve the pain, or else he cannot walk. In grade 2, he can still continuing walking. He can still continue walk even with pain, but he has to walk with effort. Grade 1 is just he has pain while walking. That's it. The severity, as we go to higher grades, it increases. There are basically these 3 grades. Coming to the claudication causes, it may be arterial, venous, or neurogenic. Arterial, it typically develops after walking for certain distance, and it rapidly resolves after 5 minutes of rest. And neurogenic, it is due to narrow lumbar canal, spinal canal stenosis can cause this. And venous, it is rare but can occur. It is observed in chronic pelvic venous obstructions as mechanical high venous pressure develops in that. It is basically due to iliac vein thrombosis, and peripheral pulses will be normal in this venous cause. Then after that, we have criteria to diagnose intermittent claudication. That is, cramp-like pain in muscle, that is calf muscle most commonly occurs, and pain develops only when muscle is exercised, and pain disappears when exercise stops within 5 to 10 minutes. This is the criteria for diagnosis of intermittent claudication. Then coming to the other word here, which is rest pain. Okay, it is a continuous aching pain in the calf or feet or toes in the region even after rest depending on the site of obstruction. It is normally called cry of dying nerves. It occurs due to ischemia of somatic nerves basically, and it can be associated with hyperesthesias and paresthesias, and rest pain is increased. It is increased in lying down and elevation of foot. Normally, this to differentiate between the rest pain and the pain in varicose veins case. Varicose veins, if the patient lie down and elevation of foot happens, there is reduction in pain. But this is opposite to that. Rest pain is increased in lying down and elevation of foot position, and it may be reduced on hanging the foot down. That is due to stasis of blood in the veins, and this is due to ischemia of nerves. Ischemia of somatic nerves. Okay, then there are few features of arterial stenosis or block in the limbs, which can be, these features are very important. These are intermittent claudication or rest pain. Any of these can be there. And cold peripheries, numbness, paresthesias. Cold peripheries because the blood supply is less to that site. and there can be color changes, ulceration, gangrene, altered sensation, and decreased function or movements. Obviously, because of pain, the function movements might decrease, and diminished or absent arterial pulsation will be there. Thrill or bruit over the stenosed artery can be heard. Okay. Then there is altered venous filling. Normally, it is in few seconds. It is delayed in arterial stenosis, and it is rapid in AV fistula. Then coming to the limb ischemia, the causes limb ischemia is basically decreased blood supply to the limbs. So basically the causes of this can be atherosclerosis, embolism, arteriopathies like Burgess disease, that is thromboangiitis obliterans, and Raynaud's disease, Takayasu arthritis, etc. And it can be due to diabetes, scleroderma as well. And the physical agents causing limb ischemia is trauma, tourniquet, and radiation therapy. Coming to the classification of limb ischemia, we've got Fontaine classification of limb ischemia, where the limb ischemia is divided into 4 stages. Stage 1, where there is no clinical symptoms, and stage 2 is where there is intermittent claudication, and that again is divided into 2A and 2B, where 2A is well compensated, that is the patient can walk for more than 200 meters, and 2B is poorly compensated, where he cannot even walk for 200 meters. And stage 3 is rest pain, and obviously rest pain is pain even at rest. Stage 4 is gangrene and ischemic ulcer formation. So this is the classification of limb ischemia. And coming to the different levels of arterial obstruction, it can be arterioiliac block, iliac artery obstruction, femoropopliteal obstruction, distal obstruction. Sorry for the disturbance in my voice, but all of these sites, these levels of obstruction can appear in the lower limbs. And features of ischemia are marked pallor, thinning of skin, diminished hair, loss of subcutaneous fat, purple blue cyanosed skin, brittle nails with transverse ridges, ulceration in the digits, wasting of muscles, tenderness and temperature. There is tenderness and temperature. And coming to other features that we see in poor circulation is delayed capillary filling, delayed venous filling, we have a few tests here to determine poor circulation. That is crossed leg test. Patient is asked to sit with leg crossed one over the other, then oscillatory movements of the foot can be observed synchronous with the popliteal artery pulsations. Along with our popliteal artery pulsation, there is oscillation of the foot. And coming to other things, we have disappearing pulse syndrome. Feel the pulse first, then exercise the limb. The pulse disappear once patient develops claudication. The pulse will disappear after this. Then we can do Burgess postural test, systolic bruit, Adson's test, or scalene maneuver. It is for diagnosis or examination. Test for cervical rib or scalenus anticus syndrome, where in a patient sitting on a stool, the radial pulse is felt first. The patient is then asked to take a deep breath and turn the face to some side. Okay. If the radial pulse disappears or becomes feeble, if the radial pulse after this turning to that side, if it disappears and or decreases, it can signify there can be chances of cervical rib or scalenus anticus syndrome. Then coming to the other tests, elevated arm stress test, that is EAST, or modified Roos test. It is for testing thoracic outlet syndrome, where both the arms are kept in 90-degree abduction position and external rotation position. The patient is asked to make a fist and release repeatedly. Make a fist, release repeatedly. Make a fist, release repeatedly. In normal side, patient will continue to do maneuvers, whereas normally in normal patient he can do maneuvers, but whereas in other patients without thoracic outlet syndrome gets pain and paresthesias, and there will be difficulty continuing the maneuver. Then we also have so many other tests like costoclavicular compression maneuver, hyperabduction maneuver, Allen's test, etc. Then coming to the investigations of arterial diseases, we have segmental pressure measurements where we will measure segmental BP at multiple levels. Then we'll have all the blood tests done, Doppler angiography, direct and aortic angiogram, digital subtraction angiography, CT angiogram, or MR angiogram, which is very ideal and commonly used now. Ultrasound abdomen, treadmill test or ECG or echocardiography, plethysmography, ankle brachial pressure index, toe brachial pressure index, Brown vasomotor index, transcutaneous oximetry. Okay, Doppler is basically a combination of B mode ultrasound and Doppler study, where the Doppler shift we observe in this is converted into audible signals. It is used to study site, extent, severity of the block and also about the collaterals. And it can also give the analysis about arterial diameter, blood flow rate, velocity of flowing blood, assessment of the stenosed segments. Then after Doppler, in Doppler there will be 3 observations we can do any case. There can be audible sound, or there can be turbulence, or there can be absence of audible sounds. Audible sound, if it is there is normal flow in the artery, or else if there is turbulence presence, there can be mild stenosis. And if the audible sounds are absent, there are no audible sounds, then it can signify there is complete occlusion or complete blockage of the artery. Then coming to the angiography, it is indicated in the conditions like thromboangiitis obliterans, atherosclerosis, Raynaud's phenomena, arteriovenous fistulas, hemangiomas, thoracic outlet syndrome, aneurysms, neoplastic conditions, other neoplastic conditions. The technique we use in this is Seldinger technique. Most commonly, femoral artery is used because it is easily felt, and cannula is easily felt to pass the cannula into the arterial catheter. Then coming to the digital subtraction angiography, here vessel is delineated in a better way by eliminating other tissues through computer system. Okay, AV fistulas, hemangiomas, lesion in circle of Willis, vascular tumors, other anomalies are well made out here. Like these main things are made out well in this because the artery is delineated in a better way by eliminating other tissues, because artery is completely neatly seen in this, eliminating the other tissues in the computer. And the procedure is first dye is injected either to an artery or vein. Injecting into a vein is technically easier, but larger dose of dye is actually required. Injecting into an artery is technically difficult, but small dose of dye is sufficient. So advantages of this DSA we call it, digital subtraction angiography. Advantages of it are only vascular system is visualized, other systems are eliminated by computer subtraction. Small lesion, its location and details are better observed with greater clarity. And disadvantages is the cost factor and availability. Complications can be anaphylaxis, bleeding and thrombosis. The other tests, as I explained, or as follows. And then coming to treatment plan for arterial diseases, firstly we have to do basic conservation and treatment, like stop smoking if this can be leading to thromboangiitis and obliterans. And then supervise, the patient has to do exercises regularly, supervised exercises. Supervised in case if he does excess exercise, sometimes can lead to other complications as well in the arterial diseases. Regular controlled walk should be done. Diet should be carbohydrate and lipid free, and there should be care for limbs that the patient should take care of it. And the patient should control. And the hypertension, if the patient is hypertensive, it should be controlled. Diabetes should be controlled, and the drugs we use in this are anti-lipid drugs like atorvastatin 10 mg, provastatin 40 mg, low dose aspirin 75 mg, clopidogrel is 75 mg, and vasodilators ticlopidin, dipyridamole, silastazole 100 mg are used. And there can be surgical intervention like percutaneous transluminal balloon angioplasty. It is done in iliac arteries, subclavian arteries, renal artery, carotid artery, occasionally in leg arteries and mesenteric or gastrointestinal arteries. PTA with stenting using expandable stents to arteries is also often done to get a better result. Then there can be bypass graft surgeries like arteriofemoral bypass, femoral bypass, iliofemoral bypass, etc. And there can be other surgeries surgical options like endarterectomy, atherectomy, thrombectomy, profundioplasty, etc. Then now coming to the diseases of arteries. The diseases of arteries I'll be discussing in the next part.